Welcome to this episode of the Twin Sister Docs Podcast.
I am Dr. Delana Wardlaw, board certified family medicine physician.
And I am Dr. Elena McDonald, board certified general pediatrician.
We would like to thank all of our past viewers, and we would like to thank any new viewers that we have. So let's get into it, Dr. McDonald. Today, what are we discussing?
Today we're going to discuss asthma and COPD.
What is asthma, Dr. McDonald? We hear about, well, of course we hear about it a lot, but let's explain it to those who are listening.
So asthma is a condition in which your lungs may overreact to different triggers. And when your lungs overreact, the muscles in the lungs start to constrict or tighten up, and they can also produce a lot of mucus, and that leads to cough, and that leads to you feel like your chest is tight. It also leads to this sound called wheezing as the air is trying to enter into the lungs, and it could cause shortness of breath. So asthma is a chronic condition that impacts millions of children and adults in the United States every year.
So asthma, is it something that people are born with, Dr. McDonald? Is it people that develop later on in life? Is it something that they keep forever, that they can grow out of? Like, what happens with asthma?
You are not born with asthma. Oftentimes within the first year of life, or the first couple years of life, you may have episodes that you may wheeze, but we typically don't call it asthma within the first year of the first few years of life. So two things about asthma. Asthma is recurrent and it is reversible. So we look for a pattern before we call it asthma. So we may look back and say, yes, this child was showing signs of asthma earlier on, but you're not born with it. You develop the symptoms later on. But again, it's recurrent, whether it's once a week, once a month, once a year, whenever you go to grandmom's and grandmom has a cat, or if you're around someone who has the dog. But there are triggers that make your lungs react in a way that a person who doesn't have asthma, their lungs do not react.
And when you speak of the cat and the dogs and so I remember as when we go to mommy's house and mommy has a cat and mommy's cat would trigger our breathing. We said, Mommy, the cat is, triggering our breathing. And Mommy would say, oh, you'll be okay. Go outside, get a breath of fresh air. Dr. McDonald, what do you say to that?
So oftentimes we have to realize that our triggers, if you could control your triggers with asthma, then you can control the asthma. Now, some triggers you cannot control.
Yeah.
You can't control the maple tree that's growing outside of your house. You often cannot control the viruses that you will contract. And viruses are one of the most common causes that can make asthma flare. But triggers that you can't control, smoke. If someone smokes near the child, they need to stop smoking. Or if you smoke, stop smoking if you have asthma. Pets, dust, mold, all of those things you can control. If we can control the trigger, we have a much better chance of controlling the asthma symptoms. So that is why when we start to notice a pattern, well, if every time you're around the cat, and yes, we all love our pets, we all love our animals, but sometimes the animal may have to find a new home if your child cannot breathe comfortably in their own home.
So many times when people say, I smoke, but I don't smoke inside the house, how does that affect asthma?
So a couple of things. One, yes, if you smoke, we prefer you don't smoke at all.
Mm-hmm.
But two, we definitely don't want you smoking in the house, because people will say, I smoke, I go upstairs, I smoke in my bedroom, or I smoke in the bathroom and there's a vent. But the smoke travels through the house. So if you smoke, yes, but if you smoke outside, still it's in your clothes, it's in your hair. So you're still bringing that smoke into the house when you come back into the house. So oftentimes people will talk about a smoking jacket. Yes, smoking jacket. Put on a certain coat when you go outside. Take that coat off when you come back in the house. Wash your hands. But again, ideally, no smoking in the house at all. If you do have to smoke outside, just put on a certain coat or clothing that you typically wear when you do that. Take it back off when you come back in. But again, it can still be in your hair. So, if you do smoke, you are still putting your child or significant other at risk.
And same thing about like if patients have carpets, if they feel like they can vacuum the carpet, and get rid of the cat dust. So again, I was diagnosed with asthma at a late stage in life, and cats are one of my big triggers. And I just remember going to one of my aunt's house. So she had had a cat before, and then I went and visited her. She had a cat. That cat practically put me in the grave. And she said, well, I could put the cat away. And I just let her know, well, unfortunately, Aunt, the cat's hairs are right. And she's very diligent about her home, and very diligent about. But unfortunately, the cat hairs are there, and I just had to remove myself. Right, I had to remove myself from the house.
Sometimes you have to physically remove yourself from the trigger, or physically remove the trigger from where you are if you can control the trigger.
And sometimes carpets have to be removed.
Yes, sometimes carpets have to be removed. And also, too, sometimes ceiling fans. Pay attention to the dust in the ceiling fans. Sometimes the people forget to dust their ceiling fans. And stuffed animals are notorious for harboring dust. So stuffed animals, if you're going to keep them, they need to be washed. They may not look the same after you wash them, but if you're going to keep them, you have to wash them. Otherwise, if they're just collecting dust, oftentimes they just need to be thrown out.
Now, is asthma a permanent thing, Dr. McDonald? I heard you mention before that it's recurrent and it is reversible. So is that a condition that the kids can grow out of, or because?
So a couple things. So when we say it's recurrent, again, the child may wheeze or adult may wheeze certain times. When we say it's reversible, it means it responds to certain medications that you give to them. So we prescribe a particular medication. You may hear the words albuterol or Venolin that comes in a form that can be in a nebulizer or an inhaler. And those particular medications relax the muscles and the lungs so that you can breathe better. So once your asthma kicks in, those muscles constrict. And we always tell people who don't have asthma, try to breathe through a straw. That is like an asthmatic. When your asthma is flaring, that's how it feels to breathe. So these medications that we use, you often hear them called rescue inhalers. They're quick on, they act really quickly. They relax those muscles to try to reverse the asthma symptoms almost immediately. Now, Dr. Wardlaw, to your question, can people outgrow their asthma? Yes, you can outgrow your asthma. So sometimes I have some patients, young patients, and they have really significant asthma. They're in our office frequently. They may be in the emergency room frequently. They may have frequent hospitalizations as they're young, but as they get older, the symptoms are not as severe. Or sometimes the symptoms could be less severe because the triggers have been removed also. So you want to be careful, when people say they outgrow it. But we do have some patients who had it as a younger child, that as they moved into their teenage years, they don't have the symptoms anymore.
And we don't have to guess on that. We have a test that we can do to determine if a patient has asthma or not.
Yeah, so there's a particular test, and we call them pulmonary function tests. Now, younger children, 1, 2, 3, 4-year-olds cannot do the test. You actually have to blow into a particular tool, and it gives us objective data where they show graphs, and it shows you what your lungs are doing. You can give these medications. You can do the test, and then you can give the medication. You can do the test again to see how their lungs are reacting to the medication. But again, you have to be a certain age to do that test. The younger children, oftentimes asthma is a clinical diagnosis, meaning we can diagnose it based off of the history and our physical findings. History and physical is so important in the practice of medicine, because oftentimes it gives us the diagnosis before we even do further testing.
And so, to your point, history and physical. So I know we're in the day and age now where we're doing telemedicine for a lot of things, but certain things you absolutely have to come to the office for so that you can be evaluated and a proper diagnosis can be made.
Yes.
Now, we talked about medications. Can you talk about this device here, Dr. McDonald, and why it is used and how it is used?
Yes. So when we talk about asthma, right? So when we give them medication, so this is called an inhaler. When you give this inhaler, you have to be able to coordinate. You have to be able to puff. You have to be able to inhale. You have to be able to keep your mouth closed so that you get all the medication. We know this is very difficult in children, and sometimes even in some teenagers and adults. So there is a device that was created, and this is called an aero chamber. And this is called a mask. And you connect these two together. And this is for a young patient why the mask is so small. So the inhaler will go in this side. Basically, the aero chamber, or a spacer, you may hear it called, holds the medicine in place. All you have to do is get a good seal over the nose and the mouth for the child. All they have to do is breathe, and it ensures that the medicine is not lost in the air. So this device is very important when we are using an inhaler in younger children.
So we'll make sure the medicine actually gets down into the lungs.
Yes, make sure that the medicine is not disappearing in the air because they're not able to coordinate and hold their breath and take the medicine in. And so this spacer is hugely important. I tell my young patients and their parents, if you have an inhaler, you should be using a spacer and a mask.
Yes. Okay. So thank you for that.
Now, when we talk about asthma, asthma is, when we diagnose a patient with asthma, there are classifications of asthma.
Okay.
So there's mild intermittent, there's mild persistent, there is moderate persistent, severe persistent. And those classifications are really based off of how often you're having symptoms. So your asthma could present in forms of, symptoms of asthma could be nighttime cough, even when you don't have a virus. Or it could be you're coughing whenever you do physical activity, or you're coughing when you're in gym class. Now, sometimes we have to be careful when they start a particular sport, their exercise tolerance may be low. So they may be, coughing a lot, but then once their exercise tolerance builds, that cough is gone or that chest discomfort is gone.
And when you say exercise tolerance, you mean that they have to become conditioned to be able to do the exercise.
Body has to be conditioned during the exercise. So if you haven't exercised for 3 months and you get up, you decide you're going to go outside and you're going to do rigorous exercise, you may feel like, oh, I'm having a little bit of shortness of breath here. But once you're exercising for a few weeks, you start to notice I'm not as short of breath. But for us, depending on the symptoms that you're having and how often you're having these symptoms, it determines what medications we put you on. So there's 2 classifications of the medication. We talked about Valium and albuterol. That's a rescue medication that you take only when you're feeling the symptoms. Now, again, if you are having these symptoms multiple times a week, or if you're up coughing throughout the night a couple of times a month, even when you don't have a virus, or you can't participate in activities like all of the other children, their friends, your peers, because you're having these symptoms, that tells us that your asthma is more significant or severe.
Okay.
So then we put you on what we call a maintenance medication to prevent you from flaring on a frequent basis. And those maintenance medications are usually inhaled steroids.
Okay.
So in the inhaled steroids, we usually have you take them once a day or twice a day, depending on the steroid. You take it every day to prevent your lungs from flaring, to decrease the use of the venom.
And I kind of compare it to like somebody is going out into the lake and they're drowning every day. If we have to rescue you every day, then we probably should teach you how to swim. We probably need to do something to prevent this from happening every day. And so we don't want to have to keep rescuing you.
Right.
So if you're using rescue medicine on a regular basis, then
Right.
your doctor will have a conversation. You got to let the doctor know too that this is happening, because they may not be aware. You don't advise them this is going on, so that they can again talk about some other recommendation.
Again, history is hugely important, but we're also again going to revisit the triggers. We want you to be aware of what's triggering you. A trigger for one person may not be a trigger for another person, but we do know that there are common triggers out there that can impact an asthmatic. So if you know your triggers, you can control your triggers. We need parents to remove those triggers. We need adults who have asthma. Make sure you remove those triggers, because that's hugely, hugely, hugely important. And once you start a maintenance medication, doesn't mean you're going to be on it forever, because we recommend that you follow with your doctor.
Yes.
You monitor your symptoms. Sometimes you will, if you're, seeing a specialist, a pulmonologist, they will do those particular studies to give them more information on your lungs to determine if we need to increase your daily medication, if we need to change it, or if we need to decrease, or we can decrease it, because you're doing pretty well.
So it doesn't have to be a one-stop shop. Once you get on the medicine, you have to stay on the medicine. It can be dialed back, or sometimes it may have to be changed. It may have to be increased.
Yes.
But triggers are key. And what about the weather, Dr. McDonald?
The weather is a known trigger for asthma.
Now, unfortunately, we can't control that.
But cold weather can trigger asthma. Can trigger asthma. We even know when it's extremely hot and humid, that can trigger asthma also. So again, paying attention to those triggers. Again, you can't control the cold weather, but we can prepare for it better. So for example, if we know that a child's asthma flares much more in the wintertime, we may put you on that that daily controller medication during the wintertime to control you so that you're not having so many flares during the winter.
Okay. Well, so that is asthma in a nutshell, Dr. McDonald.
Yes.
Common condition. We can see it in young. We can see it in old. We can see it in middle age. It is recurrent. It is reversible.
Yes.
And it can be resolved. We'll add another R to it.
Yeah.
It can be resolved.
Sometimes it can resolve, but if not, we have enough medications to treat asthma. I often tell my patients, I don't give elevator passes for asthmatics. I don't excuse you from gym because you have asthma. Because we have such good medications for asthma, we should be able to control your asthma to allow you to go out and behave like everybody else.
And we really do need to control it because, unfortunately, we have had deaths from asthma.
Yes.
People do die from asthma. So this is not a condition that needs to be ignored. And if your child is having symptoms or if you're having symptoms, you really need to be in tune to that, have a conversation with your doctor, follow the recommendations, and change or avoid the triggers that you can avoid.
Right. And not only that, not only do we have people who die, but we have children who miss a lot of school because their asthma is flaring. So if you're not in school, you're not learning things you need to learn. Sometimes they can't participate in the activities they need to participate in because their asthma is flaring. That's why we want to stay on top of the asthma. And again, we could have you on as much medicine as possible, but if you have a cat that is in your home that is impacting your child, the medication is going to be very difficult. It's going to be very difficult for the medications to control the asthma. Sometimes you have to remove the trigger if you can remove the trigger.
And that's not always an easy conversation. We know people don't always want to get rid of their pets, but sometimes we have to
just find a home. Find a home where you can go visit.
Yes.
Visit your furry animal.
Right? Yes.
So with that, Dr. McDonald, Dr. Wardlaw, I'm calling you me.
Well, that happens sometimes, Dr. McDonald. Hey, it's okay. So
that's Dr. Wardlaw. When we talk about lung conditions, what about COPD that we see in adults?
So COPD is an acronym for chronic obstructive pulmonary disease. And COPD, it comes in two forms: emphysema and or chronic bronchitis. And unlike asthma, COPD is irreversible, where it causes irreversible damage to the lungs. And the most common risk factor for COPD, I'm sure you all can guess it, smoking. Again, so we're back to smoking. And so again, this is why it's so important that you will hear Dr. McDonald and I revisit this on many occasions. But COPD, there are some non-smokers that can get COPD as well. And when we say smokers, and this is where secondhand smoke comes into play as well, people who are exposed to secondhand smoke, cigar smoking, people have to be mindful of that as well. So these are all risk factors for COPD. Now, there's also people, work exposure. People were exposed to, different type of elements at their work, whether it's different fumes or, dust or occupational exposures. There are some genetics. There is a genetic condition called alpha-1 antitrypsin deficiency that can cause people to be at higher risk for developing COPD. So again, smoking is the most common risk factor, but it is not the only risk factor. COPD, it can affect the lungs. We have this, you have to think of the lungs, it has like it's like a tree branch that comes down, the airways come down into the lungs, the oxygen comes in and it goes into the lungs, is transferred into the blood, and that's how we get oxygen to the rest of our vital organs. Are there any particular medications that we can use to help treat it once we're diagnosed with it? And so before we step into that, Dr. McDonald, when we talk about it affecting the alveolar, it can cause, the next think about it is the tree branch that has these, the airways, and then they have little grapes right on the end of the tree branches. Yes. And so that allows for the oxygen to come in and be delivered to the rest of the body. And so that ability to be able to do that is affected with the emphysema. And also you have an significant inflammatory response as well that causes increased mucus production. That's what leads to the chronic bronchitis. Bronchitis is well overdiagnosed on many occasions. People coming all the time, I have bronchitis.
Bronchitis is this excessive mucus production on a repetitive basis, and not just you get it one time and you have this bronchitis, way over diagnosed. But that's for another conversation. But so those are the two forms of the COPD. And so what we do with COPD is, one, try to avoid the triggers. Two, because the triggers can lead to exacerbations where you can have COPD and the goal is to keep it under control, right? And so there are medications that we use to keep it under control, and that usually involves inhalers, right? And so the inhaler medication is medication that you take on a regular basis. You do have rescue medication as well, but again, this is where we have a class of medications that helps to dilate the airways so that you can get more air in, and then you have medications to help decrease the inflammation and mucus production. Oftentimes that is an inhaled steroid, or sometimes people have to take steroids by mouth to get this under control too if they have a flare up. Yes. People with COPD are at risk for recurrent lung infections. So sometimes they have to go on antibiotics more than the average person. Sometimes people who have severe, significant COPD are on what we call prophylactic antibiotics, where they may have to take every day or every other day. So we do have ways that we treat the COPD. The COPD is monitored too with those pulmonary function tests that is done to see how much air is getting in, how much air is getting out. Because with COPD, it is an obstructive disease, meaning that air can get in, but it's difficulty getting out. And so then air trapping can occur where the air is in. So now you can't allow more air to get in because it's just, it's just stacking, right? So that is COPD. Oftentimes you have to follow with a lung specialist, the pulmonologist, to not only follow the symptoms, but also to do the diagnostic testing to see if it's staying the same, if it's getting worse, if it's improving. Unfortunately, we do not have a cure, but the goal is to keep it under control. Yes. And for people who have underlying lung disease like COPD, in addition to asthma, there are vaccines that we recommend, that we highly recommend. Flu, yes, pneumonia, RSV once you get to a certain age, because people who have underlying lung disease are at higher risk for developing these infections and or developing complications from these infections.
Definitely more likely to have complications from these infections. So as a pediatrician, we definitely recommend that our asthmatics get the flu shot.
Yes.
And another important thing we're talking about, we go back to talking about asthma. Family history is so important, because we do know if you have a family history of asthma, it increases your risk of developing asthma. Doesn't mean if your mother or father have asthma, you will definitely get it, but we do know that it increases your risk of possibly developing asthma based on your family history. And one other thing about asthma, when we talk about treatment, we talked about the inhalers, but there's also the nebulizer, the machine. You can also use it for people with COPD too. But the nebulizer is a machine that you use, and the medication, the albuterol, comes in a liquid form. So basically, it just kind of vaporizes the liquid, and you'll see the steam coming out of the mask. So that's another way that you can give the medication to your asthmatics and to individuals with COPD. And as Dr. Wardlaw talked about with COPD, sometimes asthmatics, they come in and they are so flared up, we have to give them oral steroids. So sometimes they come into our office, they are wheezing so bad, they're not responding to the rescue medications the way that we expect them to. We want to try to decrease the inflammation as quickly as possible. That's where the oral steroids come in at. So again, the oral steroids, if you're in the office, are trying to prevent you from going to the ER. Sometimes you go to the ER, we're trying to prevent you from getting admitted. But the oral steroids is just a short burst for a few days. Inhaled steroids is what you take every day to control the asthma from flaring up.
And when you say oral steroids, that means you take a pill by mouth.
Take it by mouth.
And when you take a pill of liquid by mouth, and when we say inhale, that's when you use the inhaler, they breathe it in.
Yes.
And so I also want to make sure that I talk about the symptoms of COPD, a chronic cough, excessive mucus production, but it could also be fatigue. It could be unexplained weight loss, because having to breathe
if you have to work to breathe, that uses calories, and if you're doing that on a regular basis, that can cause you to lose weight, and that is a symptom that patients need to be aware of as well.
Yes, and when you have to think about breathing, something's wrong. Breathing you do subconsciously. It is seamless. You do not have to think about breathing. The minute you are thinking about your next breath, and you're concerned about, you're making a concerted effort to breathe, that is a problem. You need to get evaluated because, again, breathing should be seamless.
Breathing should be seamless. So with that, we're going to wrap up asthma and COPD, but we're going to transition into allergies, which sometimes we see allergies and asthma and going hand in hand. So let's talk about allergies, Dr. McDonald. We have environmental allergies, which are allergies where you're exposed to dust, pollen, mold, various environmental allergies. Pets, smoke, and then also you can have food allergies.
Yes.
And so food allergies can be
quite significant.
Can be quite significant, and it could be a variety of foods. It can be peanuts. It could be milk.
It could be eggs. It can be seafood. So those are the most common food allergies that we typically see. So yes, allergens. So despite popular opinion, you're not born with an allergy. Your body has to develop the allergy. So your body sees it, and then it will develop the allergy. So oftentimes you may say the first time he ate peanuts, he had a little rash. The second time he had peanuts, then he got hives on his face. The third time his eyes were swollen. So the more you see the allergen, oftentimes the reaction gets worse, especially with the food allergy. So people may often say, well, I have a history of peanut allergy, so I don't want to give it to my child. You don't know unless you introduce the food to the child. And so that is a key thing to remember. You're not born with an allergy. You have to see the allergen first, and then your body develops.
So you have to have some type of exposure.
Yes.
And then your body sees the exposure, and it release all these histamines from the cells, from the mast cells that we have in our body. You have this allergic reaction due to the release of the histamines, and then that's why when patients take medications, antihistamines are medications that we usually to reverse that allergic reaction that we're seeing. An allergic reaction, particularly when we're talking about foods, it can be hives. It can be, and hives look like welts. They look like welts. They're raised welts, and they come and go. First you say, oh, I saw it on my arm. Then it was on my leg, and they're itchy. Hives are very, very itchy. If they don't itch, not hives. But there can also be throat swelling. There can also be eye swelling, but they also could be vomiting, right? There also could be diarrhea. Sometimes the vomiting diarrhea aspect may be missed from the allergic reaction. However, those are the common things that we see. Depending on what those symptoms are, now we have to determine how to formally diagnose it, how to treat it. And so there are things that we can do to treat to diagnose the allergy test. There are allergy tests that can be done. There are blood tests that can be done. There are skin tests that can be done.
That is the gold standard, the skin test.
Because the blood test, sometimes in medicine you have a test and it is not fully accurate.
It can give you what we call a false positive.
A false positive, meaning that you can do an allergy test and it says, this patient is allergic to milk. But if you're eating milk every day or drinking milk every day, and you're not having any symptom, that's a high likelihood that is a false positive. And on the other hand, if you are eating milk every day and you are having symptoms and it says that you're not allergic, then you could be milk intolerant. You may not have a full allergy, but the false positives we have to be very mindful of
with food allergies. So
with food allergies.
Parents will come in and say, can you just test my child? I want to see what they're allergic to. My answer is always no. Always no. If your child is not having any symptoms, then we don't want to go do a test that could potentially come back and say, oh, he's allergic to all of these things, but he's been eating them perfectly fine. So no, we do not recommend just going in and doing a routine allergy test if you're not having any symptoms. And that's the reason why. And then the skin test, where you go in and they expose the child to the actual allergen and see how they react. And it's usually done in a controlled setting. So if a severe reaction occurs, then they can get the medication that they need to treat the severe reaction. That's not something that is done without having the ability to be able to attend to a complication if it occurs.
Yes.
So Dr. Wardlaw, if a child definitely has a food allergy, what is the recommendation as to how we manage these food allergies?
So, but the recommendation is, one, avoid it if you can. So that involves reading food labels. You're absolutely going to have to read food labels. You're absolutely going to have to talk to your allergist and your primary care doctor, your pediatrician, your family medicine physician about how to read the labels and give you information from the Food Allergy Network as to how to identify ingredients that can be labeled in various ways. You can have milk that's labeled as casein or whey, and so making sure that you are aware of those labels and those ingredients, and medication that can be used. Sometimes you take a medication on a daily basis, or sometimes you have to take medication if the reaction occurs to stop the reaction.
Yes. If there's accidental exposure.
If there's an accidental exposure.
You need to stop the reaction.
Yes. Now, what I have in my hand here is an EpiPen. Now, an EpiPen is used for severe allergic reactions. If a patient is having difficulty breathing, if they're
lip swelling, throat swelling,
eye swelling, if they are wheezing, if they're wheezing, having severe wheezing, if they're having like a stridor, like they have this noise that they're making when they are trying to breathe because they're struggling to breathe. And so this is an EpiPen. And an EpiPen is used to immediately stop the reaction.
Yes.
And so people who have significant reactions or an anaphylactic reaction or at risk for that should have an EpiPen. And this is an EpiPen. This is an EpiPen trainer, so it doesn't actually have medication in it. And so what you do with the pen is you have to literally have to give yourself or your child
or your friend
EpiPen, right?
or an EpiPen.
Yeah.
To remove that cap off the back.
It typically has a cap on it. You have to remove the cap, and then you have to put it in your thigh, and then you have to click it and give yourself or the child or whoever's having a reaction. And then, very important, once you give the EpiPen, you have to get the child, the individual, to the emergency room. You do not give an EpiPen and just say, okay, we're going to see what happens.
Right.
You have to give the EpiPen and get the individual transported to the emergency room so they can be further evaluated, because they may need additional medication. And we have had instances where people have been nervous or anxious about giving the medication. Please, you've had this conversation with your doctor.
Yes.
They have prescribed you an EpiPen. You have gone over
the symptoms
indication,
required,
the symptoms for why you need to take it. Please, if those symptoms arise, you want to make sure that you do that. You want to make sure you use the EpiPen.
And one other thing, say you pull the EpiPen and you realize it's expired. Give it anyway.
If you're in that situation,
give it anyway, and you're still going to go over to the emergency room, okay? So one thing we say about EpiPens, it's better to have it and not need it than to need it and not have it. Most of my patients have their EpiPens. They usually don't need it, but the ones who did need it, so thankful that they actually had it readily available.
If your child or anyone you are close to has an EpiPen and the time comes to use it, please do not hesitate to use it. With that, we're going to wrap up. Asthma, COPD, allergies, know your triggers, avoid them, treat when indicated, make sure you're following up with your doctor. We'll see you on the next episode.